So the title is Double Vision, seeing family-centered care from the medical and parental perspective. And so I'm just very happy to share these are thoughts with you tonight. Disclosures: I'm the immediate past president of the American Academy of Cerebral Palsy and Developmental Medicine, just stepped down after our great Quebec meeting. I'm also the neuromuscular editor for JPOSNA and JAOS, and really kind of how this ties in along with my pediatric orthopedic career is we're the parents of two young adults with CP. Carol says they're maybe not quite so young anymore. They're 27, but they're still young. I think they're young compared to us, but so still young adults with CP going through that transition from post-college into the adult world. So I'm going to just run through. I just wanted to show these pictures of our kids. We know the cerebral palsy definition, and we know the big deal from us, from an orthopedic surgeon, is that their orthopedic issues change over time. And it's the most common childhood onset disability in the United States. This is a picture of Benjamin, born at 28 weeks in the NICU. He was our largest of the three triplets. And you can see there, Benjamin, Mason, and Claire, all in a single baby swing, probably at around 32 weeks or so before they started heading home and then starting our life with the children, with the triplets at home. So just the outline of what we're going to share tonight is we're going to talk a little bit about some of the family stresses that occurs for families of children with childhood onset disability. And one thing that I really like to focus on is really where the families are coming from in terms of guilts and doubts, and how they have issues with trust, specifically how they have issues with trust with us as the healthcare providers. And so, of course, I've been on both sides of that. So I'm happy to share our experiences with that. And then we're going to talk a little bit about family-centered care. That has some, that lots of hospitals use that terminology. We do here at Nemours at our DuPont Cerebral Palsy Center. But what does that really mean? And that actually has some specific things in the medical literature. And so I'll talk a little bit about that to kind of describe what that is. And then I'm going to talk about this biopsychosocial model of health, because I really am, that's the thing that I'm most excited about what we're doing in terms of our research and trying to bridge that gap between me from a parent to a healthcare provider. And I'll highlight real quickly some of our recent work in that area. And then we're going to do Carol's commentary. So my talk should be about 15 to 20 minutes. And then Carol will give her commentary. I know that's probably what most folks want to hear about anyway, and hear her talk and give commentary on some of the things that I've laid out there. And so there's just a picture of the kids there. All right. So family stresses with a child with a disability. And so this is one of my favorite paintings. It's Anguish. And we came upon this painting a few years ago and reading about some of the emotions of that family's experience when they have a child with disability. And obviously this particular depiction is about particularly a life and death situation. And fortunately, as we care for families with children with cerebral palsy, we don't have to deal with this a lot. But I think it really expresses all of those feelings of the grief that families go through of having to adapt to some of the changes of their dreams and visions of what they had about children. And that changes as their child goes through different stages of childhood and development. And, we were the gracious guests for Kerr Graham and his team at Melbourne. And we were actually there at the art museum, and we turned the corner and saw this enormous painting, the original painting, right there on the wall in Melbourne. And so it was really one of the highlights of my trip there. So I just wanted to share that with that. So another way to think about the stresses that the stressors on families with children with disabilities is a care map. And some of you might have seen this before. Folks with lived experience might have had the opportunity to draw this out. And hopefully some of our healthcare providers have been experienced with this as well. This is where you really put on paper everyone that touches the lives of a child with special healthcare needs. And it ranges from issues about physical issues. School is a big part of that. Different types of emotional support. And then, of course, healthcare is one of that too. But if you look at this big thing and everything in this very detailed depiction of this particular child's family. The healthcare part of it is just this one small part down here. So there's a lot of other things and a lot of other moving parts. And so I think it's really incumbent on us to try to meet the families in their area of need, to try to minimize any stress that obviously some of the healthcare issues pile on top of them. So real quickly, to just kind of go through some of the literature on this. There's one of my favorite studies that have been done is a study from Europe called Sparkle. And this was a fantastic series of research that looked on parenting stress in a European cross-sectional study of children with CP and their families in Europe. And overall, I don't think any of us would be surprised to know that those parents scored really high on the stress scores. But one thing that was interesting was that the parents of the children that had communication issues, if they had pain or intellectual disabilities, that was higher. And there really wasn't associated between the high stress and the motor impairment. Seems like despite the motor disability, these families were able to cope with some of that stress. And so that really hits hard in an orthopedic clinic where we focus a lot on walking. And I'll talk about that in a minute. What about issues with trust? So I really struggle to try to help our families trust us and to try to help them make the right decision. This was a study on a qualitative study that looked at the experience of parents of children with CP undergoing surgery. And there were lots of issues themes of concerns that these families gave about trouble establishing trust with their caregivers, trouble where they lacked that healthcare providers had the awareness and sensitivity of nonverbal children and how we would sense their reactions from their children. And they felt doubtful, unfortunately and sadly, that the healthcare providers were going to appropriately meet their children's needs. So I think this should be a wake-up call for us. What about family feelings of guilt? I think this is something I think our families deal with a good bit as they go through this trajectory of having a child with a disability. This was a great study from our colleagues at the University of Toronto that investigated families and parents' beliefs regarding the value of walking. And in this group, pursuing walking was associated with being a good parent and maintaining hope. And that as children had some tapering or diminishing of their walking ability, those families had associated feelings of guilt and doubt, unfortunately. So what is family-centered care? How can we help families get through some of this process? And this is another type of care map. This is actually from the books published here out of our DuPont Institute. Dr. Freeman Miller, who along with Kerr Graham is a giant in the field of cerebral palsy, literally wrote that textbook, both of these textbooks, one on the guide for caregiving, as well as one that's a seminal orthopedic textbook. And this is a typical family-centered care map. And you can see it's kind of similar to that care map that we talked about before. And we're proud of our CP clinic team, and we feel like we can provide family-centered care. One of the things, though, that I'm most proud of that I've done since I've taken over for Freeman since his retirement was we added a couple of things there. We added psychology and social work that was integral into our clinics. And I'll talk a little bit about what that looks like later on. So here's some other literature in family-centered care. Talks about two sides of the mirrors, about parents and service providers' views on that. What are parents' perceptions of family-centered care? What about family-centered perceptions in rehab, as well as some differences of children with CP? And they use this thing called MPOC, or the measures of processes of care, to measure parent perceptions of family-centered care. But overall, the themes in all of these papers was that parents want better coordination of care. They want more and better written information that we're able to give to them, so that they can take home and integrate those questions. They want contact with other similar families. Who doesn't want to be part of a community? And the other thing is they want more psychosocial support. That was very clear through all this. So one of the more specific things about family-centered care is, again, this issue about balancing hope and realism in terms of walking. And this was another qualitative study. And this was from the perspective from the providers about what did the physical therapists feel like in terms of their balancing hope in terms of family-centered care. And these PTs talked about how they balance their beliefs and expertise with families' goals of walking, to maintain that hope and rapport while trying to balance that with evidence-based care. And I think it's important to acknowledge our own internal conflicts. They had internal conflict when they're attempting to kind of balance these things to try to help those families still maintain hope. So again, I think this highlights that need for psychosocial care. I think we talked about care coordination for family-centered care. So I think modern care coordination has to have some version of a medical home. I think one of the issues, obviously, we think, I'm an orthopedic surgeon, so I think the orthopedic care and the musculoskeletal care that we give is really, really important. But really, we really should aim towards healthcare systems that have really high quality primary care as well, and then have that musculoskeletal care closely aligned with primary care. The American Academy of Pediatrics has some excellent resources on medical home and CP. Gary Liptak and Nancy Murphy, two really great leaders in our American Academy, wrote that original article and was updated in 2022 with Gary Novitz taking the lead on that. And I was happy to be a small contributing editor for this. There's lots of practical suggestions in this text, actually, about components of medical home and how we make healthcare environments more inviting and family-centered for families of children with CP. And they suggested we have some specific care plans that really we're able to give to them. Again, we go back to what the parents wanted. They wanted better written information. A registry, a list of all patients. Obviously, Australia has taken the lead in that. And we really look up and hold the great work that all the Australian registry, CP registries have done. And we certainly aim to try to emulate that in the United States the best we can, given our healthcare system. We should have accessible buildings and changing rooms. And we should have parent advisors and patient advocates to provide input, both for their care as well as research. And again, mention care coordination and explicit co-management with specialists. And I pivot on that to kind of talk about this biopsychosocial model of health. And you can see this gets into a little bit of the ICF model of disability. But you can see we have obviously issues of biology, social issues, and then issues of health that all kind of intersect. And this is from the American Orthopedic Association, and it goes through and nicely details really the impressive work that's happened through my career in adult orthopedic surgery. And it looks at the importance of the biopsychosocial model of musculoskeletal health. It talks about adults that have rotator cuff disease, that need hip replacements or total joints, or they're needing even carpal tunnels or adult spine surgery. All of those patients, their outcomes are directly related to their preoperative biopsychosocial environment. And if that's the case for typically developed non-disabled adults having typical run-of-the-mill orthopedic issues, how much more true is it of our families of children with disabilities? And this was one of my favorite reviews. Peter Rosenbaum's had a lot of contributions to our literature, but this review article in Developmental Medicine a few years ago I think was outstanding. And he talked about how the ICF, how environment matters. Obviously, we know what's important to persons with disabilities. And for us in the pediatric world, the child's main environment is the family. And we know that these families' well-being is impaired in some way in most instances. So this family-centered care really should address those needs of the families, and maybe how we go about that, how we support them, the literature information we give them, how we walk them through, how we evaluate them and maybe support them in a psychosocial matter. Maybe that's more important than the actual medicine that we give them, or maybe from our perspective, the actual surgery that we actually provide them. Real quickly, I'd just like to highlight some of the work that we've done on family-centered care since I've gotten here and taken over for Dr. Miller. As I mentioned, I'm most proud, really, of, Dr. Miller and duPont and others have done great orthopedic work. I think we've solved a lot of issues about what's the best surgery to do in certain environments. But now I think we need to focus on kind of a broader sense of really trying to help these families come to grips with when there's the right time to do those surgeries, and what is the right environment to do those surgeries, including the rehab environment. So one of the things that we did here was identifying factors of family psychosocial risk in CP. This was presented in the AACPDM meeting out in Las Vegas. And we used the psychosocial assessment tool, or the PAT. It's a validated instrument in HEMONC, and it identifies psychosocial areas for risk for families. So the purpose of our paper is we did a scoping review to try to identify areas and themes of psychosocial risk in families with children with CP, and map those themes to the domains of the PAT. And just a sneak peek, we're working on trying to develop a CP PAT for the future. And so I'm really, really excited. We have that psychologist that works full time in our clinic now working on that project. And CANS, I presented a project that we did with our child life group. That the purpose of that study was to develop and pilot a questionnaire to measure families' feelings of preoperative preparedness and education, as well as their postoperative coping strategies after MLS, SEMLs in children and adolescents. So this was a qualitative analysis of a questionnaire that we developed, and we looked at all our multi-level surgeries, families that had multi-level surgery in 2023. And some of the content analysis was the caregivers identified the most important aspects of feeling prepared for surgery. Again, back to that preoperative information and the resources provided, thorough interdisciplinary discussions, that's that care coordination, opportunities to ask questions of the care team. And then here's where some of their coping strategies that help postoperatively, helping them, the families themselves, leave the hospital for short periods of time, reading, praying, and watching movies. And then again, back to what we talked about before, speaking with family and friends and other parents who had children in the hospital as a means of support. Here's some of our other published research just to touch on quickly. We've looked at the health-related quality of life in adolescents with CP and how that might be different from what their parents may report for them, which was very interesting. One of the first things we did that we published there in Behavioral Sciences was we looked at our preoperative biopsychosocial assessment and felt that we were able to decrease length of stay after spine fusions. And then one of the things I'm most proud of was an invited editorial that I had in Developmental Medicine talking about promoting peace of mind and the importance of wellness for children with disabilities and their families. So I think you can see there's this shift, I think, of focus on really trying to do family-centered care and research in that area. So just some of my perspectives. I think understanding that family psychosocial environment really impacts everything. And I know personally, as well as what I've observed over these 20 years, as many families struggle to fully understand that scope of the trajectory of having a child with a lifelong disability. And we need to provide those services and identify them. And I think we have to really give them realistic expectations. So that preoperative education should be important. And then the surgeon goals and the family goals should really be closely aligned. And so in closing, what I teach our orthopedic residents and fellows, we shouldn't overpromise the surgical results. It's not about our ego, right? And we have to be honest and open and informative with those clear surgical goals and help the family articulate those goals so that we can try to meet them and align them. And really what I want to say, what I always felt like I wanted about our own children was I wanted to help the family navigate these times so that, which I think are critical for how they face the future. We want to be able to look back and know that we made the right decision for our children. And I think this type of work that we're focusing on now, hopefully will help other families be able to make those decisions. So thank you. Those are all the slides I have, and I'm going to turn it over to Carol and let her give some commentary on
Do you want to go back to the beginning?
Whatever you want. Where you want a picture? Or you want a picture of any? What picture do you want?
Put those babies up there.
Okay. And then
the pretty pictures.
That one.
Yeah.
There we go. Okay.
Just so you have something to look at while I talk to you. We really could probably go through Wade's talk slide by slide, and I could tell you why he made that slide, because I fear that it was personal experience or what he was observing from his wife, understanding the importance of the psychosocial piece. Benjamin, Mason, and Claire were born at 28 and a half weeks. They were very premature, but still, they were all home before their due date. And honestly, I thought the hard stuff was over. I thought we had lived through the NICU, we had lived through bed rest for weeks, and I thought the hard part was over. But because I had three, I had a preschool in our home, if you will. And so I knew that Claire was starting to move and the boys were not. And so by 9 months, Claire was crawling and Mason was doing a little commando scoot on the ground, and Benjamin still wasn't rolling over. And I knew that we were not meeting some milestones. I'm going to tell you, Wade was not, the expert on cerebral palsy then. And I was a I was a journalist. I had no idea what the days should look like. I just knew I was the mom and I had to cheer them to the next place. But cheering can sometimes go awry. And as I cheered them to walk and to move, I knew that we were clinging to that gross motor skill of walking that was so important. If we went to play dates with other moms and their babies, everyone wanted to know if they were pulling up, if they were cruising on furniture, and my boys just frankly weren't. And as I began to hide out a little bit in our own home and not expose myself to the pain of comparison, I knew we had to deal with this. And so we began physical therapy and occupational therapy and speech therapy. And yet no one was really working on getting the boys crawling and walking. And they kept telling me that they were delayed, that their motor skills were delayed. And that was a word that I pinned everything on, because we know what delay is, right? We were fortunate when we flew to Australia this summer that we were delayed, but we got there, right? We got there. And so this is how you hear that word, delay. And it's certainly how I heard it. And I was waiting for us to get there and to arrive. And so we began to do the therapies, and as our physical therapist would get the boys in the walker, Mason was all about it. He wanted to move and he wanted to groove. And Benjamin, frankly, would look at everybody like, she'll carry us. We don't really have to do that walking. And he was quite content to be on my hip or in my lap. And so when the therapist began to talk about a wheelchair, I shut it down and I called it the W word, and I refused to let them use the full word in front of the boys, because that might rob them of hope. And it's only, all these years later that I can say it was me that I was trying not to rob from hope. And so we moved into a wheelchair only after Benjamin had started preschool, and he would walk there. He'd get out of the car and he would use his little walker and he would get into the preschool, and he would be so tired and he would be ready for a nap. And so one day we were at physical therapy, and the therapist was working on getting him from the stroller, which I was still getting him to therapy in, to his walker. And she cajoled and she, coerced and begged, and he's finally in it, and he's standing backwards in this walker. And she said, "How are you going to turn yourself around?" And my sweet 4-year-old said, "Well, I guess I'll do the hokey pokey." He didn't miss a beat. He was funny and he was charming. He was adorable and he was smart and he loved his friends. And I was causing him to enter every experience, every event, every school day exhausted, because I couldn't get out of my own way. And so we decided that it was time to try a wheelchair. Benjamin's entire world changed that day. His paradigm was never what mine was. He was always more focused on his ability to talk and communicate and make friends than he was these gross motor skills that every single parenting book and every single parenting website and every doctor wanted to talk about. He knew he wanted to talk. And so we began to move down the road of a family with a power wheelchair and a son with power sticks, which is what we called our cuff crutches and still call those power sticks. And we moved into some orthopedic surgery seasons that were just hard. We had years, maybe a decade, I think, where we had a surgery every summer, one of the boys or both of the boys, and they were hard. And I'm going to tell you that it was by the second or the third surgery that I realized I was married to a surgeon sitting beside me in the waiting room, telling me what I could expect after the surgery, And yet I was still dreaming, hoping and praying that this was the surgery that would make things better. That this was the surgery that Benjamin just might wake up and want to try walking again. Or, he had a hand surgery and he was a teenager, and I knew we were doing it to stop a deformity, but I couldn't prevent myself from sitting in that waiting room hoping that he'd be able to use that hand that he had never really used before once he came out of the surgery. It is very hard to be the parent and to know things or to not know things, and to be looking at your beautiful child that you've had these hopes and dreams for, and now you're walking down a path that you don't understand and that you weren't trained to walk. And even when you have wise fathers sitting beside you, it's very hard to convince yourself that this might not cure the cerebral palsy. Expectations are very important to talk about. Benjamin and I have the privilege of sometimes getting to meet with families before they have a spine fusion, or things that maybe a nonverbal child can't ask the questions and mom needs an answer. Benjamin's great at helping her walk that walk and to tell her what she can expect from the surgery and the recovery. And he does a beautiful job. And we do it because we know how hard it is to go into these seasons of surgery and recovery and rehab and therapies without good expectations, without realistic goals and dreams. So when Wade says that the biopsychosocial piece is so very important, it's because he's seen firsthand that we can talk ourselves into or out of a lot of things as parents. And when we're facing a life-altering, possibly surgery for our beloved babies, it is very hard to sometimes stay on the realistic path. And so I'm grateful for the work he's doing. I'm hopeful for it. When I talked to Benjamin about, 22 years in his power wheelchair, he just lights up. It still was a beautiful, joyful day for him. And so I try to give myself a little grace when the guilt is taking over that I didn't get him there faster. A little grace for the surgeons that come into our room and our life and the things that we have to walk through. It has been a road that we've all learned from, and hopefully what we're learning is how to help the next generation coming behind us, how to help the mothers, how to help the children, how to help the service providers.